One of the topic of treatment of IPF is the broadening of the population to be treated with the new drugs. And in this sense, the Impulses trial and the Tomorrow trial before the Impulses, they have been innovative in the way that in this trial we enrolled patients with a more extended definition of IPF. In other terms, the vast majority of the patients in the Impulses trial were the patient with definite UIP pattern on high resolution CT scan or with UIP on a surgical lung biopsy. However, about 1/3 of the population were characterized by the presence of traction bronchiectasis but the absence of honeycombing, and they didn't have any surgical lung biopsy. Now, when we did compare this population with the features of possible UIP with the population with definite UIP, we get two extremely important results. The first result is that these two populations, they progress at the same rate, which means, broadly speaking, they have the same disease. And the other important point is that they had the same benefit from the drug. So the reduction in disease progression was similar, was 50%. That's why we think that this broadening of inclusion criteria in clinical trial will also help us to establish new diagnostic criteria in the future guidelines for IPF. And that's because the inclusion criteria in the context of the clinical trial were very much controlled, and so we are confident that these might be reproducible in clinical practice. One of the questions with the new drugs for IPF is when to start treatment. And that's a difficult question actually to answer, but we have some hints or some answers from the Impulses trials again. Because in the Impulses trial there was no upper limit for FVC percent predicted as an inclusion criteria. So the patient had to have an FVC above 50% with no upper limits. That means that we ended up with at least 25% of the population in the Impulses with an FVC above 90% at the time of enrollment. And these patients were a mix of patients with very early disease and patients with early disease and concomitant emphysema. Now, from analyzing this population and comparing these with the patient with more advanced disease, we derived two very important messages. And the first message is that it doesn't matter when the patient starts in terms of disease stage. They will always lose more than 200 ml per year. So the rate of progression is similar in early stage and more advanced stage in IPF in terms of absolute decline. Of course, in terms of relative decline is different, but in terms of absolute loss of FVC is the same. And the other important information is that the group with an FVC above 90% FVC percent predicted at the time of enrollment, they have a larger effect size of nintedanib as compared to the patient with less than 90%. And we don't have any real explanation for that. There are hypotheses. And one of the hypotheses is that in order for a drug which is taken orally to reach the lung, you need a quite preserved structure of the lung in terms of vasculature, in terms of anatomy. So there is a suggestion that the more preserved is the lung, the more available will be the drug in the lung, so more effective. And this is one of the major reasons for supporting early treatment of these patients. But the combination of the two, so the loss of lung function at any stage, and potentially the higher side effect in patients with early disease, they both are the fundamental for deciding to treat this patient at early stage more than in advanced stage. For every drug, one of the challenges is the long-term treatment. And these apply also to the new drugs for IPF, because usually the duration of a placebo-controlled trial is limited. And in this case, is limited to 1 year. So we are not going to have any placebo-controlled data after 1 year of treatment. And this is one of the problems for the long-term safety, in particular, of the drugs. That's why the phase 3 trial, usually, they plan to have a so-called rollover study, in which every patient translates from placebo to active drug, and the patient on active drug, they remain on active drug for a long period. So the rollover studies, they are not useful to interpret efficacy anymore because there is no placebo arm, but they are very helpful to identify the potential emergence of new side effects after 1 year of treatment. The same is true for the Impulses trial. We have the Impulses On trial, which is a rollover of Impulses. It will last for many years, and virtually every patient will stay on nintedanib eventually until they die. And we have now data after 2.5 years of treatment, and it's very reassuring to see that there are no new side effects emerging, and it looks like the safety of this drug is maintained over time. Of course, this is more important in the context of the fact that we want to treat patients with early disease. That means that ideally, in future, we'll be treating patients for many years. That's what we hope. So it is reassuring to know that there are no new side effects for nintedanib, that the safety profile is confirmed, and we will look forward to the results of the Impulses On in more and more years of treatment in order to be even more reassured about the safety of this drug. It's interesting to know that in the recent American Thoracic Society conference in Washington last May, new data have been presented on the long-term safety of nintedanib, and in particular Dr. Imre Noth presented a poster suggesting that there are no new safety concerns about cardiovascular events, and this is also true for diarrhea and for bleeding, which is making the long-term use of nintedanib reassuring in terms of treating patients with IPF.